Good evening, one and all. This is Shagni, the designated moderator from Clearnet for this session. Clearnet is very proud to be a part of this webinar as a digital partner. Now, before we move on, I'll just like to play a short video which captures the intro of Clearnet. Thank you all for your kind patience. As we all know that Clearnet is India's largest live digital CME and doctors-generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com, where you can watch lots of live sessions conducted by doctors with great expertise all across the globe. We also have MedWiki service, which is a medical Wikipedia, which is also exclusive for the doctors. We are very grateful to the association and the star-studded panel with such highly affiliated doctors to be associated with us on our platform. Now, before I hand over this session to Neha ma'am, I just would like to go through a few things. I would like to kindly remind you that whenever a doctor or a participant is presenting a presentation on the virtual stage, I would like the other participants to keep themselves muted for smoother audio streaming. And also, while any faculty member is taking up the virtual spotlight to speak, I would like them to keep their video on as well. Now, without further ado, I would like to hand over this session to the project coordinator, Dr. Neha Patel, ma'am. Ma'am, if you may please take the virtual stage.
Thank you so much, Sagnik. So we are a heartily warm welcome for the relaunching of E-Gurukul Pathshala PG Clinic, which is a very favorite program of all the PGs, especially in Gujarat and also all over the team E-Gurukul Pathshala and mainly project in charge, Professor Dr. Yogesh Parikh sir, who is Vice President Central IIP West Zone 2023. I request sir to invite our IAP President and Secretary and please give some insights.
Thank you, Dr. Nehal Madam. Warm welcome to Dr. Upendra Kinjwarkar sir, President IAP, and Dr. Vinit Saxena sir, HSG IAP, and Dr. Basavaraj is joining within a minute. Our patron guru, Dr. Y.K. Ambedkar sir is traveling and he will be joining in the soon. Dr. Ramesh Kumar, our IAP immediate past president, busy in the meeting. He will join later. And warm welcome to Dr. Baldev Prajapati sir and all our PG students and the mentor and the HODs of the Gujarat, Goa, and Maharashtra, and all the participants across the country and the globe. Warm welcome to our expert faculty, Dr. Preeti and Preeti Patel and Dr. Kinjal Bakshi from the Raipur. Over to Dr. Nehal Madam. Nehal Madam, hello. Dr. Nehal Madam, please.
Yeah.
Dr. Upendra Kinjwarkar sir, please bless us with the words.
Yeah, good evening. Thank you so much, my dear friend, Dr. Yogesh Parikh. Respected Dr. Baldev Prajapati sir. I cannot see Dr. Ambedkar sir. My pranam to you, sir, if you are here. And of course, all the great luminaries over here, my dear colleague from EB, Dr. Neha Patel, Dr. Vinit Saxena, and all the Dr. Preeti Patel, Dr. Chinmay, Dr. Ankur, everybody who has joined in from different places. So this, I think, PG training program, all of us take it very seriously, and IIP from all fronts is taking, leaving no stone unturned to reach to PGs at every nook and corner of the country. I was associated, in fact, I was with Dr. Yogesh Parikh last 2 years, wherever we were traveling, and we used to be room partners many on the occasions. And Saturday evening, the Sunday, the program used to happen. I remember Yogesh would say at 5, 1 minute, 1 ghanta, 1.5 ghanta mujhe chhod do. I have my Pathshala, E-Gurukul Pathshala. So you're so committed. And of course, salutation to Dr. Baldev Prajapati, sir. Year and year after year, he is so committed and he's so passionate about teaching any student. So that's why this year Central IP also is so committed for PG. One of the 5 Ps that I talked about is PGs. So from Tuesday, Wednesday, Thursday, Friday, all of us have this PG Reach program. And of course, Saturday, this will be there. So as much as you can train PGs, nothing like it, because each one us are ultimately aiming for the best trained postgraduate students. So you are ultimately going to take care of our children of the country. So the best clinical knowledge, if you have in this, your budding years, I'm sure that you'll go a long way when you're actually becoming a clinician, because what you learn in theory and what happens in practice, it has to be cohesive units. So that otherwise, if you do not do that, I think theory is entirely different, and practically talking to the patients, the communication skills, the demonstration of clinical signs, and so the correlation with clinico-pathological things, and ultimately making a provisional diagnosis, going to the confirmed diagnosis, using judiciously the labs, so on and so forth. And I'm sure with the help of great experts who are here to guide you, please take full advantage and block your Saturday evenings for E-Gurukul. And of course, Tuesday to Friday to IP's PG Reach program also. I wish this program a grand success. And thank you so much, my dear Dr. Yogesh, Dr. Nehal, and everybody for being here, and happy learning to all of you. Thank you so much.
Thank you so much, sir. So now I invite Dr. Vinit Saxena, sir, to please bless the event and relaunch.
Thank you, Dr. Nihal. Respected Dr. Ambedkar, sir, for patronizing this very important program. Dr. Baldev Prajapati, sir, I think most valued teacher of the country, even person who is looking for prod shiksha like me will like to listen each and every word of Baldev. And I am most happy person because 2 of our executive board members, my dear Yogesh Parekh and Nehal, is going to take lead and for relaunching for this program. This, of course, this is a program by Gujarat IAP, but viewers and listeners are PG students of every part of the country. Contents are extremely good, and I think this will create a history for this year also. So I must congratulate Yogesh for making a very wonderful team. All 3 coordinators, Madam from Pune, then Dr. Vaishali from Goa, and our own Dr. Nihal is coordinating, and enthusiasm and motivation from young people, Chinmay, Ankur, and to AD. So my best wishes from Indian Academy of Pediatrics office and president. I'm also always there to support this very good mission. My best wishes. Thank you, Yogesh, for calling me. Now over to Nehal.
Nehal, you are muted.
So much. Thank you so much, Vinit, sir. I do not see Dr. Basavaraj sir yet. So
Dr. Vaishali madam is there and Dr. Aarti madam is joining. So Vaishali madam.
So before that, I will invite our own Dr. Baldev, sir. He is the convener for these last so many years. So, sir, please bless with the words.
Dr. Nehal, sorry to interrupt. Our own is entire entry calls him our own. So it is.
Yeah, our own. Yes.
We are the privilege to have him.
Good evening, friends. Thank you very much, our President, Dr. Upendra, our Honorary Secretary, Dr. Vinit Saxena, our Vice President, Dr. Yogesh Parikh, Dr. Nehal, all faculties, presenters, and participants and students. I think in this modern era of technology, all of us know that our focus is changing. Gradually, this clinical medicine is getting rusted. Recently, I've written an article because it was asked me to write. And I realized that before it is really getting rusted, we should think for that. And I think Indian Academy of Pediatrics always ahead. And particularly this team, Dr. Upendra and Dr. Vinit Saxena, they have definitely focused on the postgraduates, particularly for this clinical learning. And I think it is quite relevant in this era when probably gradually we are forgetting this clinical medicine. And I'm sure that simply from the analysis of the symptoms, we are able to reach even sometimes the uncommon condition, which probably you may not get after these sophisticated investigations like CT, MRI, or echo. So I think that's the beauty of medicine, and all of us know that when already advanced countries they are focused on only the advanced technology, I think we are getting sometimes good appreciation
Yes, madam.
that how we are able to discuss these things. And probably then I say that when we were students we had no option, we had no advanced technology, and therefore teachers used to teach that how best you can derive from this history examination and in its interpretation. So I think that's the beauty of this medicine, and that our Indian Academy of Pediatrics, particularly the leaders, our president Dr. Upendra, Dr. Vinit Saxena, and all other office bearers, they have taken, I would say, very right step to sensitize all of us. And all of us know that not only the students, all of us are learning mutually. To be very frank, Dr. Upendra, I should confess over here on this platform that since last few years, as I am more involved in this teaching, I am probably more learning. Daily I feel that, oh, this was something new. And I think that's a mutual learning. This is a very good platform which our Indian Pediatrics provided to all of us. And always at the end of my session, I always put a word of appreciation to our office bearers. And I'm sure that in the future also, they will continue for this our learning. Thank you very much. And thanks a lot, particularly for personally for giving this opportunity. Over to you, Dr. Nehal.
Thank you so much, sir. I remember, sir, like our Gujarat's patron guru. So he was my external examination, and I am having his blessing since then. So thank you so much, sir. I have my two other project coordinators. So I invite Professor Dr. Aarti Kinikar, ma'am. Is HOD Pediatrics at BJMC Pune. Ma'am, please share your views.
Madam had some difficulty due to network problem. So Vaishali madam is there.
Okay, so my another colleague, and she is helping me for coordinating this project in our waste zone. So Professor Dr. Vaishali Joshi, ma'am, HOD Pediatrics at GMC Goa. Ma'am, please share your views.
Thank you, Dr. Nehal. Yeah, I'm having little issues with the video, but I think my audio is clear.
Yes, ma'am.
Yeah. So thank you. Thank you, Dr. Yogesh Parikh, sir, for including Goa Medical College in this Gurukul team. Our PGs had been attending this program since its inception. And I think including us will really benefit them further. Probably they'll also have a chance to present. And really, they will do wonderful under stalwarts like Dr. Amdekar, sir, and others. So I would like to extend my thanks also to IIP President, Dr. Upendra, and all other stalwarts. Thank you. Thank you for including us in the team.
Thank you, ma'am. Dr. Aarti ma'am has joined. So if ma'am, it's okay with your connection, you can share your views also.
Good evening, everyone. I just traveling, so you may or may not hear my voice, but this is a good initiative. I have been a part of the previous one, and it's really encouraging to interact with the PG students. Actually, we also learn a lot from them. You know, it's not that it is we who guide them, but that is the best thing that's happening. And I will thank Dr. Yogesh sir and his team for making us a part of this next session of E-Gurukul. So over to you, and best of luck for the entire session. Thank you.
Thank you so much. So with the blessings of all, we are starting our relaunching of the E-Gurukul Pathshala. For today's session, we have a PG case discussion on cardiovascular system. And for that, we have two experts. So first of all, I invite Dr. Preeti Madam. She is a pediatric cardiologist at USA. And she has done her MD from the Ampisha Medical College. So even though she is at the Chicago, USA, she is still one of the us. And we always, whenever we talk to her, we always feel like she is one of us, not Indian, even Gujarati. So welcome, ma'am. We will be I'm sure that all the PGs and we all will be benefited by your own special expertises. Her academic achievements and the professional career is so long in her CV that I thought I am a very small person to introduce her. So there is a long list and I was just going through it and it's difficult to include it, but she is expert in her area and we are going to learn much more from her. Welcome, ma'am.
Thank you so much. Thank you for having me.
I also welcome our another expert, Dr. Kinjal Bakshi, ma'am. She is consultant pediatric cardiologist at Narayana Health in Raipur. Ma'am has done her FNB pediatric cardiology from Amrita Institute of Medical Sciences, Kochi, and she has established the first pediatric and fetal cardiology services in the central India. And she is involved in various activities related to pediatric cardiology, including teaching with the local IOP. She is providing cardiology services to NICUs and PICUs across the country. So welcome, ma'am, for today's event. And we are sure that we will learn many things from you. So with this, today's presenter, we have today's presenter, Dr. Chinmay. He is a third-year resident from Medical College, Surat. And we have his mentor, Dr. Ankur Patel, who is associate professor at GMC Medical College, Surat. So I welcome both the presenter and mentor, and all the best, Chinmay.
Good evening, everyone. Good evening, everyone, esteemed faculty. First of all, I would like to admit something before you all. Seeing all of you giants, I find myself very small. Please kindly bear with my shortcomings. I would like to begin with my presentation now, if you would allow. So the informant in this case is the mother, who is a reliable informant, presenting the case of a 2.5 months old female child named Sabia Sayyed, born fourth in order out of a non-consanguineous marriage, who is a resident of Kalika Nagar, Unpatia, Surat, and belonging to lower socio-economic class as per modified Kupuswamy classification, admitted at New Civil Hospital, Surat, with the complaints of inability to take breastfeeds well since past 2 to 3 days and complaint of fast breathing since past 2 to 3 days. So the mother complains of the baby developing inability to feed for 2 to 3 days. The baby tries to breastfeed but stops suddenly. There have been similar episodes since past 2 months, but it has worsened since past 3 days. There are episodes of fast breathing and dry cough. They appear during breastfeeding. These get a little better after a few minutes when the baby leaves the breast. These are not associated with change in position or vomiting. Also, the baby develops beads of sweat over face during breastfeeding. These appear on and off since past 2 months and have become more frequent for the past 3 days. The mother notices that the baby has not been gaining weight like her other children at this age. I would like to discuss with the negative history.
Chinmay, just can you stop sharing?
Sure. Sir.
I think before you provide more information, let us try to analyze whatever he has already spoken. You know, he has given this title in the flyer that it's a case of cardiovascular system. But you know, when you are sitting in your OPD, the patient does not know, even you are not aware, that what's the problem with the child. And therefore, it's very important that how you are attending the problems or complaints of the mother, how you are analyzing. And therefore, it is very important. Forget regarding all the information. And that's why I thought that let me interrupt you before you go for further information. How you will analyze these complaints which a mother made. He said that 2.5 months female child is brought to you. Suppose if you are sitting in the OPD and mother complains like this, that even forget regarding the other complaints. First focus only one complaint, that is inability to take the breastfeeding since 2 to 3 days. I hope that other students are also there. Please, I request that to keep your video on and participate very easily in the discussion so that we can learn more. Just remaining present on the screen, probably we may not be able to learn the way in which probably you can learn with the active participation. Or Chinmay, you can just help me mentioning your friend's name. You must be aware of it. Who are other friends on the screen? I'm sure they may not be unhappy. They may not be happy with you, but I'm sure that it's not the problem. Later on, they'll be happy with you.
Of course, sir.
Dr. Ananya, I think Chinmay,
I want this voluntary participation.
So Dr. Dhaval is also a student. And
okay, Dr. Dhaval, please come on. Yes.
Yes, sir.
Dr. Shahid.
Yes, sir.
You are from which place? Just can you inform?
James is Surat, third year resident. Sir.
Okay, you are third year. I think third year resident is the very appropriate person to take it. Yes. As I said, suppose if you are sitting in the OPD, mother complains inability to take the breastfeeding since 2 to 3 days. How will you take it? How will you try to ask your other problems or questions to the mother, gather the information and try to derive that what is the likely problem?
So first of all, I would like to ask if they are having proper position while breastfeeding and proper timing of breastfeeding is there. If mother is having adequate secretions of or not, if child is having good sucking reflex or not, I will check that. Then I'll check about the sensorium of the child. The child might have some.
I think sorry, Dr. Shahid, to interrupt you. You know, he said that the problem is just 2 to 3 days.
Okay, sir.
And very rightly, I will appreciate your approach that many a times a common issue is a feeding problem. But you know, feeding problem will not be of only short duration. Probably mother might be facing from the beginning. But here, and even I think further he has taken some details later on that even in between child is finding some relief also. Not totally all right, but probably the problem decreases. And then again, probably the same problem is faced by the mother that the child is not taking properly. In that situation, what will be a thought process? Your first, I will say, thought is absolutely right. Go in the details whether is it some feeding problem? Is it really some retracted nipple? Really that there is no good latching? Whether the baby is having some issue of taking? So many problems with that. But you know, that will be from the beginning. This is for the, I will say, very short period and repeated problems. So I think it is something different. How will you take it? Please go ahead.
Then, sir, I will ask about any recent history, if associated complaints are there with or not. If patient is having some short illness like cough, cold, fever,
Yeah.
and sensorium, if child is sleepy, lethargic,
Suppose,
associated with not
again,
taking sleep.
if I interrupt you, very common. That mother complains, otherwise child is fine, no problem. The same age, 2 to 3 months old child. And comes to you that having some mild fever and cough for a few days, since 2 to 3 days, and now the child is not taking pills properly, remains irritable, constantly somehow the crying. What it can be, the common, I will say, condition in our daily OPD.
Commonly, if patient is having inconsolable cry and associated with fever, then it might go with some CNS infection also. But in usual OPD cases, if patient is having acute respiratory infections, upper epiglottitis infection, nasal blockage, that can also cause that child will not have a good sucking.
Which type of the lower respiratory, which starts with the upper respiratory, and later on you found that yes, the child is even breathless also, and not taking feeds. Then what is your diagnosis? I think very common.
Lower respiratory tract, that's
There
lower
is some
respiratory tract that starts with
there is some fast breathing. There is some indrawing. When child is crying.
bronchiolitis, acute
Bronchiolitis.
bronchiolitis.
Why you have to take so much time? I think that is more common rather than the cardiac. Cardiac will be uncommon for me, as being the general pediatrician. On the contrary, these will be the common. So the point is, you have to start from very simple. Absolutely, you are right. Even sometimes nasal block can be there. Even some upper respiratory acute problem can be there. Lower respiratory, which starts with upper respiratory and then lower respiratory, all of us, the bronchiolitis is common. Respiratory syncytial, influenza, parainfluenza, any of these viruses may be responsible. Okay, but you know that now the question, one other is the fast breathing. How will you take it now? I think Chinmay has gone in details. That even the finding the difficulty in taking the breastfeeding particularly, then the child stops for some time and then getting some relief. Then again the child is taking feeding, and meanwhile even the mother has noticed some sweating over the forehead. Now with this information, how will you go for further analysis? I think somebody else, please. I want Dr. Dhawan, come on. We want the multiple students involvement so that all of us can learn.
Sir, history is typically suggesting of suck cycle with perspiration over the forehead. So only this cycle in our pediatric is related to cardiovascular system. So I will go for look for the cardiovascular system. Is there any murmur or cyanosis is there or not?
What type of let us forget regarding murmur. Right, you know, so many conditions without murmur, and so many conditions murmur, but there is no any importance of this even cardiac condition. So forget it. The point is, try to focus that the child is having the feeding problem the way in which we describe. That takes for some time, particularly becomes more breathless at the time taking the breastfeeding. Then child stops even to take the breastfeeding. And meanwhile, this type of the perspiration or something, what does it indicate? Or in other way, due to what type of the problem these manifestations develop? Anybody? Tabal, you can take it further.
Congestive cardiac failure.
Okay, I think you can absolutely, your point is valid, that it indicates that there is some cardiac problem where the heart gets exhausted with this exertion.
Yes,
and
sir.
therefore getting some rest, and again child is able to manage. This type of story is very classical. Why this in the bronchiolitis, this type of problem is not there? Respiratory problem, what I mean to say, that child is taking some rest, feeling better, again takes this feeding. Why there is this type of I would say complaint or story is not there in bronchiolitis? Why it is in cardiac problem? Chinmay, you have any explanation?
So regarding if we are suspecting heart disease in patient, and if the patient presents with complaints such as when the baby is taken away from the breast, the symptoms get better. So it happens to be that, sir, as you pointed out, that because of exertion, the baby is desperate to suck the breast and is unable to because of the cardiac condition. There is a
Chinmay, my question is, I think that part we understood. But my question is, why that type of story is not found in a respiratory case? Suppose in a case of bronchiolitis, classical example I am taking. In bronchiolitis, you know that the child is not taking breastfeeding, that means not taking. Right? Unless it improves and feels better. Why interruptions are not found in a respiratory case? Why it happens so?
So, sir, in a respiratory pathology such as bronchiolitis, the condition is already persistent, whereas in cardiac.
Absolutely right. If we try to understand your respiratory problem, suppose the classical example, very easy for us to understand bronchiolitis, it is due to the hypoxemia, right? So hypoxemia is going to remain persistent till child improves. And therefore, whatever the phase of the distress is there, it is going to remain constant. While here, what happens in the cardiac case, that it is due to the exertion of this myocardial tissues, and therefore it gets exhausted. By getting some rest, again, myocardium is able to get some energy. And after the I would say consumption of energy, again child is able to do the activity. You know, similar things you must be learning in the older children or adults, what they complain in the cardiac case, that I become the breathless after walking some distance. Then I have to sit down for some time. I feel better. Then again I am able to walk for some time. You know, these type of stories, very classic in the adults, they complain. And that indicates that by sitting, by taking the rest, heart is getting some rest and even able to conserve some energy, and therefore again able to do some activity according to this available of the myocardium tissues. So I think that's the thing, that how we can differentiate, is it respiratory problem, is it cardiac problem, or something. And very rightly somebody said that with this breathlessness, with this suck rest cycle, or the prolonged period of breastfeeding more than 30 minutes, or in the sweating is due to what? Why there is sweating in a case of, it's a sign of cardiac failure, we said, it's right. But why there is sweating? Which mechanism? Which factor is playing the role? Anybody? Shahid or Tawal or Chinmay?
A sympathetic drive.
Absolutely, very good. You know, it's a sympathetic overactivity. With the failing heart, sympathetic part comes in the action, because it is trying to help the heart. And with that, of course, there is some sweating. So it is, in short, indirect evidence that sympathetic system is in the action. And it's a probably part of the help to the myocardium. So I think this is the thing, that how we can differentiate. Now, if third point, if I add, which already I think he has made, Chinmay presenter, that the mother has noticed the child is not gaining the weight. Now how will you take it? Shahid, what does it, how it helps you? Not gaining the weight, suppose some mother says, anybody? Chinmay, what is your interpretation? Already we have discussed, but child is having some inability in taking the breastfeeding, right? Later on we thought that there is the child is having the fast breathing also, and even some perspiration also, and such a child is not gaining the weight also. Now how will you take it?
Sir, for a patient who has all these complaints, and if the mother also complains that the baby is not gaining enough weight, it could be, what comes to my mind is either the baby is has already been breastfed much less than the normal counterpart, and secondly, the baby with fast breathing requires a lot of energy consumption. And so or whatever feed whatever calories the feed is providing to the baby, much part of it is consumed in the sympathetic overactivity, and that may be causing fat loss and not enough gaining weight with the baby.
Anyway, I think good attempt. Chinmay has tried to explain very nicely. And this is very important for the pediatrician, that always plot on the growth chart from the birth weight to whatever the weight readings you have. And if you see, then you understand that at what time baby started to falter. And when the child is not gaining the weight, I will say constantly it remains below the third percentile, we realize that some factor is there which is not allowing the child to grow. Then various explanations can be there. As you said, in a case of suppose cardiac case, where the left to right shunt, which is very common at this age, presenting in this way with the failure to thrive, because due to this constantly breathing problem or the cardiac failure, child is not able to take the feeds properly, which already we discussed, that it is issue is there, and therefore inadequate intake. Second thing, due to the cardiac problem, even more energy is required, so more consumption, which is already getting even I will say negative, it goes down. And repeated sometimes infections, suppose pneumonias, then again due to this chronic or repeated illnesses, child will not grow and sometimes even go for the malnutrition. So various reasons in short are interplaying the role and ultimately results in not gaining the weight or failure to thrive. So I think that's the point which we should take in. But here I think one more point last, I think then we'll go to the experts. What is another condition or group of the disorders where it may present with even again the fast breathing? But here there may not be the indrawing, no sound, just tachypnea, and even failure to thrive, not gaining the weight. And it is not cardiac problem. It is not respiratory problem. What it could be? Come on. Anything comes to your mind? And that is also very important. Dhaval or Dr. Shahi?
Severe dehydration with severe metabolic acidosis can present with distress.
Okay, but Dhaval, here it is not the short 5-7 days time where the diarrhea or some dehydration. This is again, yes. Mother says that birth weight was good. Later on the problem started and this fast breathing. And even you are also observing that yes, respiration rate is quite high, 60, 70. But there is no indrawing, no sound. Even you auscultated suppose and there is no chest signs. Even there is no murmur. Or even suppose if you have done the echo and there is no cardiac problem, suppose, then what it could be? The point is I want to sensitize you that many times we are missing because our focus is on the cardiac problem or respiratory problem or something else. And here also the child is failure to thrive, not gaining the weight. Which group you should keep in mind?
The inborn errors of metabolism.
Very good, very good. That fast breathing without indrawing or sound, it indicates metabolic acidosis. In the acidosis, there will be just fast breathing. May not be other manifestations, may not be even chest signs, may not be any murmur, and even child may not be. Of course, then maybe some these other cycles also that suppose viral infection precipitates, then fever, cough, and then vomiting, and then child has fast breathing due to the acidosis, sometimes hypoglycemia, convulsion or something, depends which type of the metabolic disorder it is. But the point is, you should keep in mind that this can also be there. Suppose if it is metabolic acidosis, not the inborn error of metabolism, what it could be? Something else. I want to sensitize you to the multiple aspects which as a clinician we come across. It's not metabolic disorder, inborn error of metabolism. Yes, metabolic acidosis is there. ABG is also, suppose if you have done it, shows this metabolic acidosis. But somehow it does not help you to say the metabolic inborn error of metabolism. Then what another disorder which can present again failure to thrive and metabolic acidosis. And even one might
renal tubular acidosis.
Very good, Dhaval. Very good. I think all of you are knowing why you are not speaking. I will appreciate you. And you know, sometimes just I was trying to give the hint that when a resident said, sir, rickets is also there in this patient. Then you know, ricket becomes a very important marker for me to think this renal tubular acidosis. The friends which I wanted to sensitize you that simply the child is brought to you with difficulty in breathing or even the feeding issues or not gaining weight. Not many points are there as a general pediatrician we should keep in mind. Of course, it can be due to the various reasons which already we discussed. I think before we go for the further presentation, I request Dr. Preeti and then Madam Dr. Kinjal, I think, if I am not mistaken. Please, you can contribute something which probably we have missed it, please.
I think you covered everything. It was a very good analysis of the symptoms and going through the thought process and differential diagnosis. Especially, I still remember my days as a resident as to how we used to think about it, as to this is what the symptoms are and how you go about going through different systems as to what is it. The only other thing I would say is if there was something neurological also that can present with difficulty breathing, if there's a central reason for it and not feeding and then failure to thrive related to that.
Chinmay, madam has kept for you some neurological condition presenting with difficulty in taking some feedings and even this generalized hypotonia. What it could be?
Either it could be related to central nervous system pathology, say meningitis or encephalitis, or it could be peripheral.
Chinmay, you know these infections are acute. They are of the short duration. Here, mother is observing that almost since birth, difficulty in taking the feeds, and even remains just lethargic. But look is bright. Yes, Dr. Isha said, very good. You know, spinal muscular atrophy that can also play. That Madam Dr. Preeti very rightly reminded us that even neurological condition can also present in this with the feeding problem. You know, the point is we have to differentiate. Yes, Dr. Kinjal, your words, please.
Sir, I think it was a very good analysis of the history taking part. And this is very important in office practice that once this history is given, I think we have to, at this stage, give a thought to all the systems in general pediatrics. So I think, sir, excellent analysis of all our systems. And I think further we can go on to see what our child is actually having.
Okay. Okay. Chinmay, you can now share your PPT and go ahead.
Yes.
And I request all the students, participants, please, when Chinmay is presenting, be very attentive. Note the point. Try to derive your inference or even some questions or query which our experts will help us to solve. Just I will say, don't remain silently present. Be very active, very dynamic. And I'm sure then and then we can learn. So Chinmay, you can share your further PPT with the further presentation, please.
I would like to continue the rest of my clinical history. I would like to take up the negative history now. There are no complaints of decreased activity or floppiness, change in quality of cry, frothing at mouth, regurgitation of feeds, indrawing of chest, noisy breathing, changes in the crying sound, blowing of nails and lips, swelling in legs, loss of consciousness, or seizures. Coming to the past history of the baby, history of similar complaints worsening since past 1 month, noticed by the mother. The patient was taken to some private practitioner, but no evaluation was done or treatment was prescribed. There is a history of on and off episodes of runny nose and cold for past 2 months. There is no history of hospitalizations, blood transfusions, or top feeding. There is also no history of contact with a known case of Cox disease. Coming to the family history, there is a history of the mother being diagnosed with a swelling in the front of her neck in the midline. It was diagnosed in the 6th running month of amenorrhea at a private hospital. Some oral medications were received for a brief period and then stopped. There is no history of asthma, Cox disease, any heart or lung illnesses. Coming to the antenatal history of the baby, the mother is gravida 4, para 4, abortion 0, live issue 4. The present pregnancy was a registered pregnancy. The course was uneventful. It was terminated at 38 weeks. 4 antenatal visits were made. Mother's blood group is A negative. 2 tetanus toxoid vaccines and 2 anti-D immunoglobulin injections were received. ANC USG documentations are not available. Fetal movements were felt in the 2nd trimester onwards. Iron and folate supplement tablets were taken regularly. No history of fever with skin rash, lymphadenopathy, gestational hypertension, gestational diabetes, or other genitourinary problems. Coming to the birth history, the date and time of birth of this baby is 6th of November 2022, 9:19 a.m. The birth weight was 2.960 kg. It was a full-term normal vaginal delivery and the baby was appropriate for gestational age. The baby was delivered at a private hospital and the baby cried immediately at birth. There is no history of neonatal ICU admission. Birth vaccines were received on the first day of life and breastfeeding was initiated in the first hour of life. Now coming to the postnatal history, the patient has been on exclusive breastfeeding on demand. There is no history of top feeding. During a breastfeeding session, the mother is able to breastfeed the patient for about 5 to 10 minutes. The patient then develops sweating, cough, and fast breathing during breastfeeding. The patient leaves the breast and goes to sleep for about half an hour. The patient then wakes up crying and latches to the breast again. Coming to the immunization history, only oral polio vaccine, BCG, hepatitis B vaccines were received at birth, and no other vaccines have been given since. Coming to the developmental history, Social Smile has appeared about 1 month ago. Coming to the socio-economic history, a family of 6 members living in a single room. The father is a daily wage laborer with no fixed monthly income. Family belongs to lower socio-economic class as per modified Kuppuswamy classification. Now I would like to summarize the clinical history, what we have gathered so far. This is the case of a 2.5 months old female child named Sabia Sayed, born 4th in order to a Rh negative mother with suspected hypothyroidism and goiter, out of a non-consanguineous marriage, who is a resident of Kalika Nagar, Unpatia, Surat. and belonging to lower socio-economic class as per modified Kupuswamy classification, with only birth vaccines received, with suck rest suck cycle present, with suspected congenital heart disease, and presenting to New Civil Hospital Surat with complaints of inability to take breastfeeds well and fast breathing for 2 to 3 days, along with dry cough, sweat over face during breastfeeding, and poor weight gain. Shall I continue?
Can you stop sharing? Sorry.
Yeah.
I think now he has provided lot informations to us. Who will analyze one by one? Students. Who will take it? The negative history, Chinmay, I think without sharing the PPT, can you take the points which you have described? What was your idea?
So I tried to rule out in the negative history what could be the involvement of other symptom, other
No,
systems.
I think you can take one by one precisely.
Sir, I would need to go back to the PPT again.
Okay, I think anyway, I remember some of the points. Your point was valid that floppiness or something already which we discussed, that with the taking feeding, that means CNS involvement, particularly generalized hypotonia and something, right? In a case of even spinal muscular atrophy or so. What other negative points you mentioned? Change in the voice quality. What was their idea? Or which condition may present the change of voice quality and the presentation which already you have made?
I had tried to mention about the quality of cry. If the mother has noticed any change in quality of the cry, any adventitious sound or any unusual.
What type of the change in the voice will help you to confirm or to exclude some condition? To consider or to exclude some condition?
Yes, sir. So regarding the quality of cry, or if you ask quality of voice, then in this 2-month-old female child, I am trying to rule out any pathology related to the respiratory system, especially any upper airway pathology.
Suppose if I give you that such a child who remains hypotonic or not taking pills properly, and there is a hoarse cry.
So this would indicate more towards a neurological pathology, very likely.
Which one?
And meningitis.
Why meningitis? The change. I say the hoarseness of voice. I said that the child is finding difficulty in taking the feeding, right? Maybe as you said, neurological part you are considering. At the same time, child remains lethargic or hypotonic, and the cry is harsh.
I'm sorry, sir. I thought it was you mentioned shrill cry. For a hoarse cry, it would be, sir, related to cranial nerve pathologies or related to.
Here the hoarseness of voice with only persistent jaundice. Mother says to me that, sir, oh, that jaundice was also prolonged and not taking feeds properly, remains hypotonic, and the cry is hoarseness. And it's a preventable cause for mental retardation. We should not miss it. If we miss it, if we miss it, probably it is punishable to us.
Sir, hypothyroidism. Hypothyroidism, sir.
Yeah, that's why I want to bring to your notice. You know, sometimes that's why I said the mother or the child does not come with reading the Nelson or even cardiovascular system that, oh, this is the textbook, now you can go further. You know, the patient will be having any complaint, not taking pills properly, of course. But when even mother may not complain, but you just child cries and you note that, oh, there's a hoarseness of voice. And child remains lethargic. Never forget it. then I'm sure that if I examine anterior frontal widely open, sometimes posterior frontal is palpable. And if you ask the history, mother will say, yes, yes, sir, there was some prolonged problem of jaundice, hospitalized, some phototherapy was given, and there was relief. And at present, we don't go routinely for the screening. That's a problem. Western country, it's a rule. Gradually, I think we are also sensitized that some of the private sectors, they go even routinely, if not all, common 5-6 conditions. And one of them is the hypothyroidism. And very important, why we are insisting so much, it's a preventable cause of mental retardation. So I think we cannot afford to miss it. That's why I'm insisting so much. That was my point, right? But suppose if it is not hypothyroidism, it is chubby child, it remains hypertonic and even the cry is hoarseness. And somebody has taken X-ray for some problem and now it is showing the cardiomegaly. And I examine that, oh, liver is enlarged. What it could be, Chinmay?
Sir, it could be something like a glycogen storage disease.
Very good, very good, very good. I wish that the students, those who are participating, right, you make your examiner feel that the student is doing better than I am doing. Then I'm sure they will get the scoring. And for that reason, gradually you should be able to suspect or answer all these conditions. Particularly, glycogen Pompe's disease. Pompe's variety presents with generalized hypotonia. Even finding difficulty in taking the feeds. And there may be cardiomegaly because cardiomyopathy is common. And maybe even hepatomegaly and maybe hypoglycemia, somebody has noted. The point is, that's why I think negative history, when you mention, you should be able to answer that, what is your idea? And the smart, I will say, presenter in the exam will speak and then give some pause so that examiner is sensitized to ask the question, right? And so that you can answer brilliantly to all these conditions. And that's the thing, that how you can score. But for that, our presence of mind should be there. We should not be, I will say, restless or disturbed during this presentation. These are the points. I'm getting your points from your negative points, right? What are the further some negative point? Can you just remind me? This is few which I noted. Anyway, I think further if you go, you mentioned cold and runny nose. Is it helping me in this condition? How it is important in my case, the way which you are discussing?
For this particular baby, when we are suspecting congenital heart disease, it is very likely that recurrent respiratory illnesses are associated with these conditions. So
Chinmay, I'm getting my targeted answer. This is common answer. Which infections are common in the shunts? Upper respiratory or lower respiratory?
Sir, it is the lower respiratory system.
Yeah, that's why upper respiratory has no value. Right, it is just, I will say, the part of routine recurrent viral infections. It has nothing to do much with the shunts. Lower respiratory, yes, we understand that due to the congestion, lungs congestion, and therefore recurrent infections, pneumonias, if you get it. So the point is probably, here you can say it may be the part and parcel of some recurrent viral infection. Probably it has nothing much link with this cardiac condition or shunt, particularly when you are thinking, right? So the point is, whenever you mention, you should have the clear ideas in your mind that how much important to be given to this particular point in the history and how much even you can neglect it, right? You mentioned some swelling in the neck of the mother. So what type of the swelling was it?
According to the mother, sir, she did not have had any documentation available at the time of history taking. She gave the history that it was in midline and it was at the base of neck, and it was in chest, at that local site. And also she mentioned that when I asked if the mother, if it was, if she was feeling any pain or any tenderness, she denied both. She did not have any pain or no tenderness.
Was it before the pregnancy also, or it developed later on?
According to the mother, she noticed this when she was through the 6 month of her amenorrhea, and when she decided to seek some medical help for that.
I think you linked up with some thyroid disorder.
Yes, sir. I am suspect. Yes.
Which type of thyroid disorder?
Sir, it could be hypothyroidism involved. It could be, sir, a simple goiter. Connecting with sir, the socioeconomic background of the family, it could be an iodine deficiency goiter, simple goiters.
I think you must be knowing iodine deficiency has nothing to do with the lower socioeconomic class. Even it can develop in the higher socioeconomic class also. The only thing that the iodine deficiency depends. Number one, there are in our country, there are some geographical distribution where this iodine deficiency goiter is common, sub-Himalayan areas, right? And second, suppose hypothalamic goiter, the surgeon is not going to operate it, right? So I think something is wrong with the link, which always keep in mind. On the contrary, suppose later it would develop, it can be simple, some abscess, it can be some lymphadenitis, or really if it was really next, somebody asked even some surgical question. What are the midline neck swellings common which you are knowing? And particularly in the children. Then at least don't forget the thyroglosal cyst, dermoid cyst, brachial, even the cleft cyst, right? Even the lymph node, so many things, right? So I think that in the exam, there are 6 examiners on the long case. And every examiner is thinking in his own way. So you have to face the 6 people with the different sets of the questions. So whenever you mention something in your case, I think every point somebody may take it. So you should be fully aware that how to answer related queries or the questions. I think before we go for, you said some termination at 38 weeks was terminated?
What I meant with that is the baby was delivered at 38 weeks.
Yeah, that's why, yes. That is not the termination word should not be used for that. It was delivered. Termination and delivery, both things are different. Termination, something harmful to the child, that fetus or the mother, where further continuation of pregnancy is not advisable or desirable. In that case, you interrupt the pregnancy, and that's the termination. Here, probably it's a good outcome. Everybody is happy, right? At the full term, baby is taken out, delivered, and you are getting the good baby and offering even the good child to the parents or the family. So it's not termination, right? It's a happy, I will say, session, or good, I will say, the occasion in the family. That's why another thing, during presentation, find out the appropriate word, because that word conveys the meaning, right? Anyway, I think these are the things which can happen, but it's a good thing that it happens over here, so that in the future we can take it, and all of us have also learned in this way only. That's a good thing. I think before we go for the further, I again will go to the experts. There I will say inputs, then we go for the examination. Madam, you can take Dr. Kinjal.
Yeah, Chinmay, I wanted to ask basically, I have gone through your PPT and your history and all. One very important negative history is missing. Have you asked for fever and all? We have not covered that point. Because primarily we are looking at probably with this history, the first differential is our upper respiratory infection, especially with the running nose and etc. So any fever was there. I think that was one very important history that.
Yes, ma'am. It is rightly pointed out. The baby, I did ask the mother if the baby had fever or not, but I did not include it because I did not find it relevant to the case.
And any gastrointestinal, because viral, it is very common that the baby may have GI issues along with the upper respiratory issues. No, this is just a mock, this thing. No, so I'm just reminding that a negative history. I mean, just take it okay. Otherwise, don't get tensed or anything. Okay. But
Yes,
I
madam.
think this is what in office practice, this is how we go about it. Even when we are practicing pediatric cardiology, the first differential for us is all these common things only. Common things first. That's all I want to say. है ना? ठीक है.
Dr. Preeti, anything from your side?
No, I think it was an excellent review and analysis of the negative symptoms and nice tips on how to present during examination.
Yeah, I think just I would like to remind, sometimes the students are giving the very long list of the negative points which are given in the standard textbooks. But what you should include the negative points. Keep in mind, focus thoughts. Number one, suppose whatever the condition, hypothetically you are thinking from the history, then related to that, whether it helps you to consider or not, that you can ask. Or as madam said, related complications. Suppose if you are thinking some congenital heart disease and with shunt, that means lower respiratory infections are common. Therefore, you should ask particularly, was there fever or even some cough or breathlessness with a child was hospitalized? Was it pneumonia? These points will help you to consider. So I will say negative points should be related to your condition or nearby differentials, which very rightly you have mentioned differentials. That it's not the CNS case, it's not the metabolic, or it's not particularly respiratory problem. So that's right, differential, that means these differentials are excluded. And third, always related complications. Suppose here you are thinking for the congenital heart disease with shunt, then is it the patient with cardiac failure? That I think that should be made clear from these negative points. That is there any point or any suppose history which is suggesting whether cardiac failure is there or not, because cardiac failure, respiratory infection, these are very common in these patients related. So that you can make it clear whether it is present or absent, right? And then it becomes a very clear background for you to discuss also. So very nicely, as Dr. Preeti said, your presentation is definitely good. We understand that what we are discussing is after several years, more than 35, 40 years. And I know that you are since 40 months in the pediatrics. So it makes difference. But at 40 months, probably we were not the way in which you are. So it is appreciable. I feel that you are much better at this juncture than we were. So your presentation is definitely good, really good. Anyway, now I think, should we go for the exam? Yes, Dr. Ankur, would you like to say anything? Ankur, unmute yourself.
No, sir. No, sir.
Yeah, I think you are a very good mentor. Ultimately, this credit should go to you.
Thank you, sir.
We understand that the students' interactions are reflected the contents of the teacher. So yes, I'm sure that we understand. You know that all of us as the teacher, directly, indirectly, we always be our SS.
Yes.
Even after passing the MD examination, when that candidate goes for the post of assistant professor, the senior teacher in the interview, they are asking, from which institution you are coming? I think that question is sufficient to understand that from where you are coming. And sometimes the teacher is asking, who was your teacher? Because he wants to know that how you are likely to be trained. All of us, and that teacher has not to ask the questions of pediatrics. I think these questions are sufficient to know that he looks from the good institution, he must have worked, and I think the teacher is known, he must have taken the care for teaching the pediatrics, and then probably he'll be helpful if I take in my department as assistant professor. I think that's the thing, that how they are taking the interview. They hardly look at these papers or even the other things. So I think in that way, Chinmay, your presentation was really good. Thank you very much. Now you can go, I think, for examination.
Thank you very much, sir. I would like now like to continue my presentation, beginning with the physical examinations. Talking about anthropometry, the baby's current weight is 2.500 kg. Weight for age, the baby stands at below 3rd percentile. The baby's length at present is 52 centimeter, and for length for age, she stands below 3rd percentile again. The weight for length is also below the 3rd percentile. The head circumference of the baby is 35 centimeters, and for head circumference for age, the baby stands below 3rd percentile. These are the growth charts I have included in my presentation. You could see the green dot in each of the three. It is well below 3rd percentile. First one is weight for age, second is length for age, and third is head circumference for age. Now, continuing with the general examination. This patient has been examined by me in daylight with full exposure from head to toe in the lap of her mother with her consent. General examination continued. The baby's temperature was 98.4 degree Fahrenheit by digital thermometer. Pulse rate was 166 per minute. It was regular in rate, good rhythm, good volume with bilateral symmetry and no radio-radial or radio-femoral delay. Respiration was 60 per minute and it was abdominothoracic. The capillary refilling time was less than 3 seconds. I have measured the BP of this baby using 2.5 centimeter NIBP cuff in each of the 4 limbs. In the right brachial artery, it was 87 by 52, mean BP was 63. In the left brachial artery, it was 89 by 50, the mean BP was 60. In the right popliteal artery, it was 90 by 54 and mean BP was 62. And in the left popliteal artery, it was 87 by 53 and mean BP was 63 millimeter of mercury. I also took SpO2 through the multipara monitor in each of the 4 limbs. In the right arm, it was 97%. In the left arm, it was 97%. In the right leg, it was 96%. And in the left leg, it was 95%. I have continued with the thorough examination from head to toe now. I would like to summarize these. The peripheries are warm. There is no pallor, icterus, cyanosis, edema, or lymphadenopathy. There is no evidence of visible opacity in the eye, dysmorphic face, wide palpebral space, or absent eyebrows. No nasal discharge or ear discharge, and no skin tags. No evidence of high arched palate, bifid uvula, no neck masses, short neck or low hairline, no skin rash or lesions and Mongolian spots, no syndactyly and polydactyly. The genitals, the back, and the spine are normal. No grunting or other adventitious sounds. No cleft lip and cleft palate. I would now like to begin with the systemic examination. I will proceed with the examination of cardiovascular system based upon the clinical history and general examination findings.
I think before that, Chinmay, can we go for focus on the general examination? Then last we'll go for this CVS.
Sure, sir.
Can you stop sharing? I think general examination, Madam, can you take Dr. Preeti? That what he should focus or whatever he has done.
I think starting, he said the peripherals were warm, so that he looked into good perfusion from the cardiovascular standpoint. Then he looked at dysmorphic features. So he went through maybe trisomy 21, trisomy 13, trisomy 18, other syndromes that could possibly be the reason for it. He looked at the blood pressures in all the four extremities. He looked at radiofemoral delay. He looked at radioradial delay. He looked at the pulse ox in all the four extremities to make sure that there wasn't any other issue from that standpoint. Rest of the general examination, I think, pretty much included everything that probably needed to be included, thinking through all the processes that he needed to.
Dr. Kinjal?
Yeah, by and large, I think you have covered the entire general examination, Chinmay. I just wanted to know that the child at birth, I mean, the weight is also below third centile. The height is also below third centile. Have you looked at the mid-parental height and, I mean, correlated? Or we are just looking towards malnutrition based on our history?
Ma'am, when the patient was admitted at our hospital, the baby was accompanied only by her mother. There was no father was available, so I could not.
Okay. Yeah, I just want to ask what kind of malnutrition do you expect in shunt lesions generally?
I beg your pardon, ma'am.
No, I would like to ask what kind of malnutrition, I mean, what parameters do you expect to lag behind generally? If you are considering shunt lesions or any cardiovascular pathologies?
Ma'am, for a suspected congenital heart disease or any shunt pathologies, a baby would lag behind in gaining height, I mean length and weight, both. And it happened that weight would be definitely lower than what we would be expecting as compared to what the lag in length would have been.
No, see, basically shunt lesions or those leading to cardiac failure, they predominantly affect the weight. Okay. The height is relatively less affected.
Yes.
This is true for shunt lesions. So, but our patient is lagging behind. The height is also below the third centile. Okay, so that is why I think we have to look into the mid-parental height and other causes as well, just to keep in mind. That's all. Okay.
Yes.
That not to be entirely attributed. We should not miss any other pathology in our child and should not attribute the entire thing to cardiovascular pathology. Okay, even the head circumference is running below third centile. I mean, that is also of predominant concern for us because our future development is entirely dependent upon it. Okay, and this is a real case. I mean, the child is with you, I suppose. So I think the other neurological exam later on you can, I mean, in coordination with your seniors. Okay.
Okay. I think any other student, somehow I don't know why they are shining. You should not shine. Dr. Esha is there. Tinkle, I think they are students. I think Madam has addressed a very important point. Here, Chinmay, I was also thinking that weight is expected, what we say, cardiac malnutrition. It's a very specific terminology is there, cardiac malnutrition. That means, malnutrition due to the various reasons. Commonly, what we attribute the malnutrition in our pediatric practice, that intake is less. Right. But cardiac malnutrition is something different. Anybody is having the idea what we mean by the cardiac malnutrition? Dr. Esha or even Dr. Dawal? What Madam said is exactly right. The commonly significant component affected is the weight. Due to the various reasons already we discussed, that due to these some cardiac failure signs, child is not able to take this adequate feeding, and therefore it results in the negative. Second thing, demand is more. Even hypoxemia is an important factor in the children, which is not allowing the child to grow. Right? And even in between these infections, suppose hospitalized for pneumonia, or even not hospitalized, but then also lower respiratory infection. These infections will also not allow the child to, it's a vicious cycle. In malnourished children, the infection is more. With the infection, more degree of the malnutrition. So that can also be the reason for this. And ultimately what happens that the 2.5 months old child only, say I'm expecting the weight, yes, but not the length. Provided the length at the time of birth, it was normal. Second, even the height circumference 35 centimeters, which is expected at the time of birth. Now the child is 2.5 months. And therefore, this is very important point, which sure even I also noted when we are talking. Such a baby, I would like to go in the details. It's a really some syndromic condition. Cardiac condition can be, with some syndromes. Of course, apparently, as you're saying, some dysmorphic features are not there. But, even without that also. Or as Madam said, very pointed out, that along with the cardiac condition, maybe the involvement of some other conditions also, like central nervous system. You can go into any brain insult, or another thing. Suppose some congenital infection in utero that can cause even the microcephaly, that can cause even the cardiac condition, that can cause. So I think the different things should come to our mind, and that always we should give the thoughts that why the head is small, why the length is even, weight okay, it is expected. So that's the point which just I noted. Another thing just to emphasize to all the students, before you discharge the baby, even normal baby, from your postnatal ward, never miss at least examination of blood pressure once. This is very important, which is probably routinely many times we are missing because it's not considered a routine, or we are not accustomed probably, but it should be. Very, very important. Here you have done a very good job. That are not only the measurement of blood pressure, but in all the 4 limbs. That is very good. That message should go to all the students. And I'm sure that in the exam, even if you have measured, whatever the reading given, examiner may not mind, but will appreciate that, yes, it's a good thing. Second, even, oxygenation. Before you discharge the normal baby from a postnatal ward, confirm that this oxygen saturation is normal. And if you have the doubt, then probably it requires a further workup, even in the absence of all other features or manifestations. So these are the very important points. I'm not sure whether you have mentioned these femoral pulsations in this patient. Probably no. This is again, femoral pulsations is very important in this way. And that too when you are suspecting your cardiac. On the contrary, I'm talking not with this cardiac condition. Any baby postnatally after the birth, when you are discharging, the certain points that femoral pulsations are very important. Because you can miss it even the coarctation of your. And on the contrary, when the patient is breathless, ascertain yourself that the femoral pulsations or even the doubt of coarctation of your. That can also present with just cardiac failure. You don't know the reason. And even the back is examination. In the newborn, many times this is it's a male child or female child? Chinmay?
Female child, sir.
Female child, okay. But in male child, suppose, never miss even to examine the this presence of these testes, undecided testes. We are not simply just focusing the murmur or cardiovascular system. We have to see the baby as a whole. And suppose if you do the very good job with cardiac condition, but afterwards somebody notices that it was undecided testes also, which even the cardiologist or general pediatrician has missed, probably it's not pardonable. But it happens so. It happens so. So I think these are the points which always we should look for. Another thing you said, Mongolian spot you have noted. Very common question, maybe in general pediatric newborn is the short case, in examination. Dr. Dhawan, are you there?
Yes, sir.
Okay. So come on, I think, keep your video on. I can see your face. I will say very dynamic face. Are you able to keep your video on? Yeah. He has mentioned the Mongolian spot. Very routinely, you must be looking in so many babies. What is that importance of Mongolian spot? Or how it happens so? Nowadays, you must be knowing that Mongolism, Mongolian spot, all these terminologies are removed. On the contrary, it is expected that we should not speak because some race people, I will say people of the race may not like it because we have derived this Mongolian word from that features, particularly China, Japan, and Korea. And therefore, the people say that now, what is the another name of this Mongolian spot? Anybody? You know, the question you don't know that somebody may not ask anything on cardiovascular system because the examiner knows that you may be knowing the echo report. So I'm not interested in the echo report, right? I want to know whether are you really fit for the general pediatrics or not. And if you are fit for general, tomorrow you can do the cardiologist, nephrologist, neurologist. Okay, fine, that's good. But first you should be the good pediatric, general pediatrician. That is the generalist, I will say. Mongolian spot. Another, you know, now the people say it's a congenital persistent melanocytosis. They say that use this one. And it's a common, but another thing, what is the importance, Dr. Dhawal, of this Mongolian spot? How much importance we are giving?
So generally,
Yes,
it's not associated with any condition. It's a benign birthmark.
Right. Very good. Absolutely right. Dr. Tinkle is also there. I think she appeared, but then I wish that what Dr. Dhawal answer is right. The Mongolian spot usually we consider they are benign. When the parents ask, even we say that it is going to disappear in some due course of time. It is not going to remain persistent. But when you will give the importance to this Mongolian spot, that's the question. In which type of the Mongolian spot or congenital persistent melanocytosis you will give the importance? Suppose if you want to score, this will be my question. Routinely, commonly we say it's a benign. It is going to disappear. Don't worry. We'll ask the parent. I will reassure them. But when suppose I may worry even, and before speaking this thing, I may speak some guarded points. Anybody have any idea?
Sir, it would be, although this persistent congenital persistent melanocytosis is a benign condition, if this macule happens to change color or dimensions with time, it would be feasible to think of melanoma or melanosarcoma in this patient. If it happens to be changing dimensions and changing, or it happens at newer spots over body or skin. And yes, sir.
Okay, I will consider that. Okay, you have some idea. Many times it happens in the exam. Then we, examiners are discussing that, okay, he didn't answer clearly, but he was having some idea. And then also at least you are getting some, I will say, marks. The point is, here, very classically, the association I'm coming to the point. Good. Association of this Mongolian spot with the malignancy was considered once in the past. Now it has been cleared that it had nothing to do with the future malignancies. But the uncommon sites, common sites for the Mongolian spots is the lumbosacral region, back, buttocks, thighs sometimes. But once they appear over the back over the shoulders, neck, these are not the common sites. And if they are really having the uncommon sites, they have reported or noted even later on the conditions like gangliosidosis or even the Gaucher disease, Niemann-Pick. They have got the association of these persistent and abnormal sites for these Mongolian spots. Then I think you may get it. I think all these are because I'm discussing for the postgraduates. I'm keeping these questions for good scoring. Practitioners will say, sir, okay, this is not important for a practice point of view. But this is important from the practice point of view also. If you are aware, I'm sure that you will put the word. And we know it's not commonly, but once a while you will come across. And that helps a lot. Anyway, the cutoff value for tachycardia and tachypnea, just to remind to the students in the exam, at different age group, who will take it? Chinmay, just you can mention what are the different cutoff values for tachycardia at different age group children.
For a newborn, a baby who is less than 1 month of age, normal heart rate would be from 100 to about 160. If
Chinmay, sorry to interrupt you, sorry. I'm guiding you from the exam point of view also. Address the question, what the examiner has asked. You must be looking this debate on the televisions. Many a times what the anchor is asking, the politician is responding to some other matter. I think the exam will not do like that. In the exam, we will address the perfect question. Cutoff value of tachycardia. So no range.
For newborns, sir, it is more than 150 or 160.
160. Okay, 160. Take the one figure.
For a child who is 1 month to 2 months of age, it is 150. It is 160. It is 150. 2 months to 6 months is 135. If I'm mistaken, and more than from 6 months to 1 year, it is 90, sir, I guess. No.
Okay, Chinmay, this is for all the students. Please keep in mind, sometimes so simple question, even examiners will think that why we should waste the time even for asking simple questions. But it happens so. Please remember in the exam. Therefore, you should be fully prepared in the examination. WHO guideline has given the very sharp demarcation. Less than 2 months, not newborn. Less than 2 months, more than 160. 2 months to 2 years, more than 120. Older children, more than 100. This is cut off, I think, that we should remember. This is just to remind you, this is exam point of view. And that will be the idea that should we consider tachycardia, tachypnea like that. Similarly for the respiration rate, when you should go for the tachypnea, right? This is just to sensitize you that please remember somebody is going to ask you these type of questions and you should be able to address. In the general examination also, so many points people ask. I will appreciate you have mentioned so many points to make the point clear that somehow there was no any dysmorphic facial features or any dysmorphism anywhere over the body that you have, and therefore syndromic condition is less likely, at least from the examination you can derive that meaning. Madam, anything else or should we go for the CVS? Okay. Naturally the experts, madam, they must be waiting for CVS findings. So now we'll take their help. Chinmay, you can go for presentation of systemic examination.
Yes. I would now like to continue with the rest of the examination, beginning with the systemic examination. I will proceed with the examination of cardiovascular system based upon the clinical history and the general examination findings. First of all, in the inspection, The shape of the chest is bilaterally symmetric with equally spaced nipples with no evidence of scar, visible veins, visible pulsations. The apex bit can be seen in the left, fourth, and fifth intercostal space in mid-clavicular line. The precordial area is seen hyperdynamic. Upon palpation, the apical impulse is present over fourth and fifth intercostal spaces in the mid-clavicular line with normal character. Palpable systolic thrill is appreciated over the left sternal border. Upon percussion, cardiac dullness was present over left intercostal space in mid-clavicular line, and the cardiac border could not be percussed because the baby was too small to be percussed. Upon auscultation, there is a loud and wide splitting of A2P2 sound heard best at pulmonic and aortic areas with mild pitch ejection click at A2 aortic area. The splitting sound S2 is heard during both inspiration and expiration. Also, there is a harsh grade 4/6 pansystolic murmur, which is heard best over a right parasternal border, which has no change in position of the baby. No paracardial rub was heard. Other system examinations. In the respiratory system, the air entry was bilaterally equal and the chest was clear with no crepitations or wheezing. Upon cranial CNS examination, the cranial nerves did not show any abnormality. The baby had normal tone and activity. Deep tendon reflexes were brisk at both knees and ankles. Upon abdominal examination, it was soft, non-tender, mildly distended, non-stretched umbilicus with no dilated superficial vein and no splenomegaly. Clinical case summary. This is the case of a 2.5 months old female child named Sabia Sayyed, born fourth in order to a Rh negative mother with suspected hypothyroidism and goiter out of a non-consanguineous marriage, who is a resident of Kalika Nagar, Unpatia, Surat, and belonging to lower socioeconomic class as per modified Kupuswamy classification, with only birth vaccines received, with suck, rest, suck cycle present, suggesting congenital heart disease, and presenting to New Civil Hospital, Surat, with complaints of inability to take breastfeeds well and fast breathing for 2 to 3 days, along with dry cough, sweat over face during breastfeeding, and poor weight gain. The patient has failure to thrive with microcephaly. Fixed split S2, harsh 4/6 grade pansystolic murmur with thrill over left parasternal border with mild pitch, ejection systolic murmur of at aortic area of auscultation and without signs of congestive cardiac failure.
Okay. Can you stop sharing now?
Yes, sir.
I think, madam, you can take one by one. Dr. Kinjal from the CBS examination, and then Dr. Preeti, you can contribute, please. You can focus.
Yeah, so first of all, I would like to know what is your understanding of the apical impulse. The description that you have made in both the inspection and the palpation. You have mentioned that you are able to feel apical impulses across 2 intercostal spaces, that too in a very small 2.5 month, 3-month-old child. So what is your interpretation of this?
What I mean by inspecting apical impulses, it was more so in the fourth intercostal space. This apical impulse is a throbbing sensation seen over skin when the baby was looked by me at the level of chest.
No, see, when you look at the apical impulses, okay, they are either hyperdynamic or they are sustained. Okay, and generally they are located to a single intercostal region only. Okay, so I think you need to have a relook at the child. Okay, so your description according to the exam has to be very crisp and very clear. Can you just tell me what are the causes of hyperkinetic apical impulses? What kind of conditions do you expect?
Ma'am, what could be the possible causes of
Possible
hyperdynamic?
causes of, yes, normally once you feel the apical impulse in a normal heart, okay, you just feel it. Hyperkinetic means you are feeling that is, you are looking at the volume overload conditions of the left ventricle, correct? And if you have a sustained impulse, then you are looking at conditions which are pointing towards your left ventricular hypertrophy. Okay, that is a sustained impulse. Okay, so can you just enumerate some conditions which can lead to left ventricular volume overload? Because what I understand from your history that we are looking at some condition which is leading to volume overload of the heart. Okay, and we are just trying to get some inference as to what can cause all this.
Ma'am, what could be causing
Volume
the
overload.
volume overload of the
heart.
left?
Enumerate some conditions. Okay.
Even Chinmay forget regarding this case. Generally,
you can just, in general, you can tell what can
in
cause
general,
volume
even
overload.
the different age group, when they, as Madam said, hyperkinetic or hyperdynamic, this type of the cardiac impulse is there, which various conditions are giving this type of the cardiac impulse.
Cardiac impulses.
It could be regurgitation or aortic regurgitation or pulmonic regurgitation causing volume overload. Also, it could present with ventricular septal defects, which are large ventricular septal defects. And if there happens to be even increase in preload, any condition causing increase in preload either on the left side or on the right side, it would present with volume overload.
See, I would like to tell you something that the apex is related to your left ventricle. Okay, so you should enumerate all the conditions which lead to left ventricular volume overload. For right ventricular assessment, you will feel the right ventricle at the left lower parasternal border, and that you have to mention right ventricular heave is present or not present. Okay, so if you come common conditions, congenital conditions, rheumatic conditions, and other acquired conditions. So congenital conditions, you will automatically tell VSD, PDA. PDA is very common. Okay, AP window. Okay, any aortopulmonary collaterals. These are common conditions. Okay, then you come to rheumatic conditions or any other congenital conditions which is causing aortic regurgitation like a bicuspid aortic valve or a congenital mitral regurgitation. Okay, common conditions first. Okay, and then the third subset which we did not discuss today, and those are cardiomyopathies, the dilated cardiomyopathies. So it can very well be present in this child, correct? The child has history of since 1 month off and on cough cold. It can very well lead to viral myocarditis and viral cardiomyopathy. And the myocarditis cardiomyopathy can also present in a similar manner. Correct. So we are having two kind of differentials here. Some condition which is causing volume overload of the left ventricle. Correct. Okay, so that is what I want you to understand. Okay, so once you are describing your apical impulse, you automatically are pointing towards some conditions. So all the differentials, one by one, systematically, we have to keep in mind. Okay.
Thank you, madam. Dr. Preeti, points from you?
Yes, so I noted down few things from his examination. The one thing during initial cardiac exam, he said no white space nipples. So that's a good thing to kind of like notice, no webbed neck or anything to rule out Turner's or Noonan syndrome. Apical impulses, Dr. Bakshi noted that. The one thing he said, no splenomegaly, but he did not mention anything about the liver, whether that is enlarged or not from that standpoint. The split S2, so the description, it seems like there are three cardiac descriptions there. One is the split S2 and white fixed split S2. There is a thrill, then there is ejection, systolic murmur in the aortic area, and an ejection click. So ejection click and ejection systolic murmur in the aortic area would suggest more towards bicuspid aortic valve and aortic stenosis. Fixed split S2 would suggest more like an ASD with having delayed P2. So that way you have fixed split S2 with the right-sided volume overload. And then a thrill. So a thrill is usually when you have a small restrictive VSD. Or sometimes you can have it in the supraseminal area if you have aortic stenosis also. So the thrill is more to be described as to where exactly it is on the precordium.
Okay. So I think, Chinmay, the one thing which everybody noted is examination should be methodological, number one. We understand that the examination of cardiovascular system in these, particularly the small babies, newborns, clinical examination is always difficult. And even how much we should rely upon your clinical findings is always question mark. Agree? Confidently what you are relying upon the clinical findings in older children may not be that easy in the small children, and that to the newborns. But in that case, what you should do, that find out these very specific positive findings and try to define it exactly. And because after this first exercise, always put your findings properly, and then precisely try to decide that how much it is reliable, how much it is question mark, and then try to put in the story that will give some idea that what condition can present in this way. I think if I start from this, what Madam said, Dr. Kinjal, absolutely, apex within a newborn, you said fourth or fifth space. Is it normal or abnormal? First decide this thing. The location in a 2.5 months old child, the fourth and fifth space on the left side, what you say, number one, is it normal or abnormal, Chinmay?
Sir, the apical impulse in this child who is 2.5 months of age felt in the fourth intercostal space, it is normal.
That's why, always again I repeat to the students, because I want to prepare you for the exam. Answer very precisely, or say don't know. Even don't take the good answer. Very good answer. Point is, norm, that means where suppose the child is normal newborn. No any problem, no cardiac problem, nothing is there. What is the normal location of apex beat? And that's why we have to know first normal. Then I can decide whether should I consider normal or abnormal. Normally in these babies, it is expected in third space, third or fourth. And if I say fourth or fifth, that means definitely, certainly my interpretation should be abnormal location, number one. Second, the type, cardiac impulse and apex beat, both are different. Cardiac impulse is the mass of the left ventricle, lower part of the left ventricle, and it's a large area, and it's a diffuse area, and then it's very classically seen in a hyperdynamic or hyperkinetic circulation, where you can see this cardiac impulse in diffuse large area. Apex beat is a very defined, very sharp area. And how we define the apex beat? It's the lowermost an outermost part of the cardiac impulse, imparting a perpendicular thrust to my palpating finger. Remember this, I will say the apex beat. It is very precise. It's the lowermost and outermost part of the cardiac impulse. Cardiac impulse is the large diffuse area of the left ventricle, which is actually very active muscle mass, which is contracting very effectively. And when particularly the lowermost and outermost part, we see the apex beat. So use the word number one, apex beat. Now, as Madam was saying, apex beat, once you say, try to define. Is it forceful? It is sustained, and it is diffuse. Try to find out three adjectives. Remember these three adjectives. If the apex beat I say it's a forceful, it's a diffuse, and it's a well sustained, it indicates left ventricular hypertrophy. Once I say it is forceful, it's sharp, it's tapping, that means it's a right ventricular pattern. Try to define. I understand every time it is not so sharp or very easy to define, but I think we will, and at least your attempt is there. Of course, you suppose sometimes your finding is wrong, no problem. Examiner will consider at least your attempt is good. And every time our attempt may not be right. But the point is, that means you are knowing, you are trying to defining, and your attempt is good. I think it is more than sufficient for any candidate even to go for the good scoring. So here now, if I come back for your interpretation, it's a fourth and fifth, that is abnormal. Right. Second thing, as Madam said, apex beat will be well localized. It will not be in two spaces. On the contrary, which I remember, the two spaces, they say that only one condition where apex beat you may locate into, and that is cardiomyopathy. Otherwise you should not get the two. So, even suppose if you said two, then also you should be able to answer. Very rightly, Madam was thinking, suppose if I don't consider it's a congenital heart disease, if it is acquired, of course, and with suppose cough cold, which you are describing, you can consider viral. Coxsackie A and B viral infections are common, and even they can cause the myocarditis and later the cardiomyopathy. Of course, in our patient it is not that, but this is also one of the differential diagnoses that we should know. Even congenital cardiomyopathy, that also we should keep in mind. Endocardial, you know that endocardial fibroelastosis can present at this age. Somehow it is, I'm not sure now, but when I was, I would say, learning the medicine, that in our country it is more common in Kerala due to the tapioca. There is some toxin responsible for this endocardial fibrillation. So, the point is when you are answering, you should have these ideas. And very important point, which are, your findings may be wrong, but your interpretation, you can put it properly. And methodologically, suppose inspection, right? I will say 2.5 months old child, why I should say the scar? What surgery somebody has done even in the 2 months old child? Not expected, so don't put it. Right, older child, okay. And second thing, what you said, the shape of the chest, absolutely right. Later, because if it is cylindrical, but abnormal shape of the chest can change your cardiac findings. It's a good point, definitely a good point. And palpation then always mention methodologically. First, heart sounds. Right. Locate the and areas also, mitral, tricuspid, pulmonary, aortic. You are going methodologically. And once you speak in that sequence, examiner understand that he knows the method. Maybe right or wrong, but he knows the method. And after the heart sounds and palpation, you can decide whether it is normal, whether it is loud, whether it diminishes, what your interpretation. And for that, first heart sound is best appreciable in mitral area. Second heart sound is good appreciable in pulmonary area or in aortic area. And second heart sound is having the more importance in cardiology. So many points it derived, they say. Sometimes you may get the short note in theory that the second heart sound. Then you should know that what is the area where you can palpate or auscultate. And then second heart sound is of two components, aortic and pulmonary. Aortic is first and pulmonary is second. Usually no splitting. physiological splitting can be there. But you know that wide splitting and fixed splitting, you know, it's very characteristic. In a case of your atrial septal defect, if it's narrow splitting, it is very important that pulmonary hypertension, loud palpable P2, that means pulmonary hypertension. You know, before this probably echo and everything, when we were trained, these were the points from where we were considering, may not be every time right, but I think most of the times, yes. Now with this, these are findings and echo, you can correlate correctly. And later on, so I think this is very important, reverse splitting and all the thing. Still, I will say clinical exam. Some people will say this modern era of even the echo and all this advanced technology, why you should go for all this clinical examination and murmurs. But I'm sure that even having some importance, I'm sure the experts can guide us. You know, sometimes examination has nothing, but your clinical examination can or history can guide. I remember, let me share, madam, one case long back, almost 20 years back, when we were not doing much even this technology. When I entered one new hospital as assistant professor, one of the colleagues said that my relative child is suffering from difficult epilepsy. So many investigations have been done. So many, even the good neurologists and pediatricians have seen, but still it is not controlled. And that patient was brought to me. On history only, I asked my registrar that tomorrow answer me these questions. Number one, is it a convulsion, seizures? If it is seizures, is it epilepsy? If it is epilepsy, what is the type of epilepsy? And therefore that whatever the drugs are given, whether they are right, what was the compliance? And now why we have failed to control this epilepsy? But my registrar, I remember Dr. Ramnathan, now he is good consultant, I will say, I'm talking about 20 years, he's working in Coimbatore. Next day, I remember even I'm learning from the student. He said, sir, it is not epilepsy at all. I said, oh, that's how could you say? Sir, I have diagnosed. And he came to me with the ECG, that was the prolonged QT syndrome. I remember even I saw the first case 20 years back, and which was taught to me by my resident. He said that, sir, it is the prolonged QT syndrome. That was the first case. I remember Dr. Nevan Anand Pandit from Pune, sir was there as our guest. And he said, sir, Dr. Baldev, very nice that you called me because I enjoyed the discussion. So, you know that every investigations were done in that patient. So that's why I want to even insist that even with this future also advanced technology and so many points are, I will say, you are going to get the gadgets. But ultimately, the presenter, interpreter, inference, drawing, analysis, the medicine is going to rule, not the gadgets. So I think that's why I think we are discussing that the examination findings is there. You know, ultimately, then you can put what are the inspection, palpation, percussion, auscultation findings. That which part is affected, which chamber is affected, how it is affected. And then you can ask, is it congenital or acquired? Is it cyanotic, acyanotic? Is it with which chamber? With murmurs and other things. And even you can take the help of X-ray and ECG, basic investigations. And then I'm sure that 3-4 conditions will come to your mind. Then we can take the help of Dr. Preeti or Dr. Kinjal. They will do the echo and they will say, yes, sir, you were thinking the last one, third one, but it is the first one. Okay, that can happen in our clinical medicine. But I'm sure this is the charm which you should put in a proper, and I'm sure that the examiner will appreciate. But Chinmay, I think you have done the very good, I will say, efforts methodologically you have examining. I think you have any further investigations we would like to see?
Yes, sir.
Yeah. Anyway, I think before that, let us go, before you show the investigation. What is our clinical inference? I think one thing which I would like to remind all the students, because ultimately, you know, this is our post-graduation session. We want to sensitize the students and to train them. In the exam, they are going to ask you the summary. Ideally from history even, what is your hypothesis? Suppose it is cardiac, then what type of cardiac problem? Not condition, not diagnosis. Whether it is shunt, whether it is some valvular reason, whether it has medium some cardiomyopathy, or really some systemic disorder which has involved the heart, something like that. You can prepare the hypothesis. And then your findings, you can define that now what is the likely problem, right? And then you can go for the further investigation for confirmation. And I'm sure this is methodology in any system, not only cardiovascular system. So Chinmay, now you have to answer what you have given the good summary, findings, everything. Now, what is your inference? What is your possibility? And possibility should be with the reasoning.
So based on the clinical history and the examination conducted so far, from the clinical history itself, it was sure that this is we are dealing with a congenital heart disease, and there was no complaint of any cyanosis in the baby. We were dealing with acyanotic congenital heart disease. And after we went through the examination part, it appears from the findings, the murmur, that what we could be dealing is more than one conditions. It could be a complex pathology, complex congenital acyanotic heart disease, something of this sort, sir. The murmurs indicate specifically that the pansystolic murmur along the sternal border, it may be, especially when coordinated with the clinical history, could be a moderate to a large ventricular septal defect. And also the ejection click was heard along the pulmonic area. It could also, it also supports the diagnosis with that. And as ma'am rightly mentioned, that it is one of the two possibilities of the other component would be aortic stenosis or bicuspid aortic valve, which also can be put into consideration. And with a fixed split S2 sound, discrete A2P2, irrespective of inspiration and expiration, we would also be dealing with what is the atrial septal defect. So according to me, it could be, it is very likely a complex acyanotic congenital heart disease.
Any opinion from the experts?
Dr. Chinmay, I have one suggestion. First of all, if you look into your auscultatory findings, you have not mentioned S1 at all. Okay. So first of all, whenever you mention in a sequence. You first enumerate all the heart sounds, S1, S2, whether additional sounds S3 and S4 are there or not. Then you come to systolic murmurs. You have not mentioned any diastolic murmurs. And of course, before the murmurs, you have told 2 clicks. Today, my question is, what are the conditions which can give you wide fixed split? There are very limited conditions.
Ma'am, atrial septal defect causes fixed wide splitting.
Other conditions? Which other conditions can cause wide fixed split? What is the natural history of ASD? Do you expect an ASD to present at this age?
No, ma'am, not at this age.
Correct.
It is not.
The other very common condition which can have wide fixed split is atrioventricular septal defect. Okay. Your AVSD can very well present at this age. It can have a wide fixed split. Very large VSDs generally do not give harsh murmurs, as Dr. Preeti has said. They are silent. The murmurs which you will appreciate in very large VSDs are generally the ejection murmurs, the flow across the pulmonary wall. Another thing what you have to study is the ejection clicks and clicks related to bicuspid aortic valve, non-ejection clicks. You have to be very specific. In your findings, you have mentioned the murmurs across the right parasternal borders. Okay, So I think in the next class, you have to study and come which murmurs will you appreciate along the right parasternal borders. In my description, I think we do not appreciate any murmurs along the, unless until you are dealing with a case of dextrocardia. Correct?
Yes. Yes.
So all, see, today is, you have to go and organize your findings again. And I think you have to get back to your mentor again, I think. Okay. And first of all, and I want you to study also the mechanisms of the split of S2. Okay. And in what conditions you will get S3, in what conditions you will get S4. Okay. And today you can just enumerate what are the causes of white fixed split that we have already mentioned. Another one important common is thing, you can just tell me the causes of pansystolic murmurs. And you should also study the grading of murmurs. Okay. You can, right now you can tell what are the causes of pansystolic murmurs.
Ma'am, again, a ventricular septal defect is a common cause of pansystolic murmur.
And anything
Also,
you can,
ma'am,
yeah.
Mitral regurgitation also present with pansystolic murmur,
and related
also
to our case, what do you think? Correct. See,
tricuspid,
your white fixed split, this is how you will correlate. Your S2 is white fixed split, correct? And you are having a harsh grade 4/6 murmur at, not right, but let us keep, it will be the left lower parasternal border. It can very well be related to your tricuspid regurgitation actually. Okay, in conditions of severe PAH. Okay, that 4/6 maybe, it may be a regurgitant murmur, not a VSD murmur. Okay, so just have a physiological assessment. So now we have come to a good conclusion. Okay, we are thinking that this patient may be having a AV septal defect. Okay, echo may be anything. This is only the discussion of our clinical findings and correlating physiology, not the exact diagnosis. Now, complex heart diseases, what you have mentioned. Okay. Now, complex heart diseases are technically ruled out. Complex heart diseases, we mean admixture physiologists or single ventricle physiologists, correct?
Yes.
Okay, not transposition, because your patient is saturating 96, 97. Your complex heart disease patient will be saturating below 90%, which may be not be clinically visible, but we have done pulse oximetry assessment, correct? So those differentials, I think we are not dealing with those group of heart diseases here. Okay, complex, telling a complex heart disease is a very broad term. So, and that is not in a way differential from our entire history, correct? So I think we are dealing only with some kind of shunt lesion. Okay, so this is the physiology. Now shunt may be anything. Okay, and it can be complicated by valve regurgitations as well. Correct. It can be also complicated by your bicuspid aortic valve. Now it can be a VSD with a coarctation, like sir has mentioned earlier, which is causing vigorous shunt. Correct. Leading to severe TR. Correct. So these are the physiologies we have to correlate, not the structural heart disease. Structural heart disease, nobody expects, not even at cardiology level. We need to correlate physiologies. But I want you to organize your auscultation findings very well. You please go through the description of the heart sounds, the clicks, and how will you describe murmurs. You please go through. Okay, because in a proper examination, this auscultation findings will not suffice. Okay, but good attempt. Okay, so our conclusion is some kind of shunt lesion. Next, I don't know if time is permitting, whether we are going through other your investigations and management part as well.
Yeah, I think now we'll have to keep in mind regarding timing also, we have overshooted, but absolutely for the students, you know, the reason is you are knowing the diagnosis. Many times you are knowing the even echo diagnosis. That is the trouble. On the contrary, you know, whatever you have the findings, first, that's why you confirm your findings. And according to your findings, whatever even what Madam said, whatever the possible physiological groups, that even sometimes you can mention the group even, not particular condition. You know what we say, that this fellow's physiology, what it mean. That means, several conditions can present with these type of the clinical manifestations. And I think all of you must be knowing in the presence of the experts that, clinically what we have discussed, echo findings may be different. And even when the cardiothoracic surgeon is operating, it will be totally different structurally. And it is very common story, I will say, not even the uncommon. So the point is, probably we cannot go with this some operative findings or echo findings or a clinical discussion. On the contrary, that's why we should go for the clinical judgment, that from this we define that this is likely this type of the physiology, that single ventricle like or Fallot's physiology or some shunt. Shunt also can be the different. Very rightly, as you said, atrial septal defect, suppose some findings are there supporting you and which is not the age, then keep in mind that it should be associated with some other problems. And therefore it is presented early. Because this is not the age for the atrial septal defect. But here suppose some findings is there, you can consider. But then you will have to keep the clause that I may not be able to define exactly that what is the associated some other malformation, but must be contributing for the early presentation, this 2.5 months presentation for the atrial septal defect. So like that. So I think this is very important. But now with this constraint of the time, let us go, Chinmay, whatever you have the investigations, just have a look and then we'll have to end over here, please.
Okay, sir. So just to wrap up, the diagnosis and the differential diagnosis. As I said earlier, what I believe is this could be mostly a case of congenital asymptomatic heart disease without congestive cardiac failure, with failure to thrive with microcephaly. And in the differentials, I have put as a ventricular septal defect with associated complex asymptomatic congenital heart disease. Now, let us move to the management part, the investigations. I would have ordered the ECG. The ECG was done on this patient and it revealed a right axis deviation with tall P waves in the second heart lid. Chest X-ray was done, hemogram was done, blood culture was taken, and due to the suspected history, mother's history of hypothyroidism and goiter, serum thyroid stimulating hormone and free T3, T4 levels could also be done, and echocardiography, two-dimensional echocardiography was done for this patient. In the management, in the treatment part, begin with the general measures such as temperature regulation and securing airway, ensuring proper breathing, circulation and oxygen support, and also salt and fluid restriction would be recommended for this patient. And after the investigations are through, we could possibly look at the surgical management. Also, dealing with the complications of congenital heart diseases itself, these patients are more likely to have associated, more susceptible to infective endocarditis. So the prophylaxis for infective endocarditis would be feasible in this patient. Also, possibility of congestive cardiac failure could be one of the complication, requiring again fluid and salt restriction and use of treatments such as furosemide and diuretics, spironolactone as such.
Chinmay, sorry to interrupt you. You have the other investigations done?
Yes, sir. I could show you
report. I think that just you can show because we'll have to wind up in this short time.
So this is the X-ray of the dead patient.
Right.
It shows cardiomegaly. The CT ratio was calculated to be found more than 0.5. Also, it shows the characteristic prominent vascular markings in both the lung fields, what is called the plethora. Pulmonary plethora is seen in this patient. And I also have to share the 2D echocardiography report of this patient.
I think for the constraint of time, probably we don't go in the details, but I think X-ray chest also requires so many comments. Can you just go to this X-ray chest? Madam, any expert would like to make the comment, Dr. Preeti, on this X-ray?
Like Chinmay already said that you can see the cardiomegaly, you can see the increased pulmonary vascular markings. The other thing to note in small babies is the thymus and to look for the sale sign. So that is one thing that you need to realize in some patients, if they do not have a thymus, then you have to think about DeGeorge syndrome for those patients. The liver, especially in the abdomen, doesn't seem to be too enlarged. That's the one thing. Not just look at the chest X-ray, look at the abdomen to look at the total number of ribs to make sure that they have 12 pairs of ribs. The diaphragm seem to be okay. They are not pushed down to suggest hyperventilation or anything.
I think, is it right that this, with the cardiomegaly, if you see that the heart is not going down, but just only laterally. So is it somehow, you know, the left side, if you see the dome of diaphragm is very nicely seen, and even this shadow of the heart is definitely above that. So maybe really only laterally displaced, that means right ventricle type. Difficult to make the comment, but I think whatever we are able to see, we can make the comment. Trachea is absolutely centrally, but I'm sure that the, you know, right and left, both these, we are able to see the bronchi, and that's angle, subcoronary angle is seems to be little bit widened. Whether it is related to, or we are able to correlate or not, it's a different story. But as Madam said, rest of the points, yes, absolutely, this right side is the thymic shadow, and it indicates that it's, you know, absence of thymic shadow sometimes may help you to say even cirrhotic heart disease, because absence of thymic shadow is commonly found. Second, even as Madam said, DeGeorge syndrome, that also I think, at least for the sake of students, we should keep in mind. Anyway, I think these are the findings. Chinmay, you can go further for these echo findings or something.
Yes, sir.
Whatever
I would now like to share the 2-dimension echocardiography report of this patient.
Yeah. I think we'll have to read it because difficult to read. You can go for the conclusion, I think.
Yes, sir. So it shows the large mid-muscular ventricular septal defect, shunting bidirectionally, predominantly left to right. Small ostium secondary atrial septal defect, shunting left to right. Bicuspid aortic valve with slightly distal transverse arch. No aortic stenosis, no aortic regurgitation, and no coarctation of aorta. Right atrium and right ventricle are dilated. There is severe pulmonary artery hypertension with good biventricular function.
Okay, anything else?
Advice has been...
No, anything else? Any further investigations or any point?
Hemogram was done for this patient and blood culture reports were sent. Blood culture did not isolate any organism. And for the hemogram, the hemoglobin of the patient was 8.3. The total count was 11,000. Platelet count was 168,000. And the CRP, the C-reactive protein, was 5.
Okay. Can you just stop sharing now?
Yes, sir.
I think for want of time now, we'll have to end over here. But I think very good presentation by Dr. Chinmay. Very good even selection of case. And what lessons even we learned from the experts, Dr. Preeti and Dr. Kinjal, and even from the whole discussion, particularly for the students, that it's really good luck or bad luck to get the cardiac case in the examination. Depends at how you are able to do it, because many a times it becomes difficult. But the point is, ultimately most of the examiners are quite mature and they will assess that how you are putting your presentation, and from that what you are interpreting and inferring from the history. That confirmation of your cardiovascular findings, what even Dr. Kinjal insisted and emphasized, I think very important. Try to define exactly, my findings may be wrong, but this is my finding. I think that should come. And with your findings, try to derive that what type of the likely physiological malformation in particular case. And on that base, you can consider the various possibilities and then plan further investigations. I think that should be the whole exercise. And I'm sure that if you have done the attempts in this way, right or wrong, but I'm sure that every examiner will appreciate. So I think that's a lesson from today's discussion with all of us can keep in mind. I think let me appreciate Dr. Chinmay. I understand that to stand for these 2 hours with even these questions, and somehow I request that next time come with your friends, real friends, that you will have to remain on the screen. You'll have to answer my whatever the queries and questions. I may not be able to answer everything, and I'm sure that in that way also you can sensitize them to learn. Today's both the experts, I will appreciate Dr. Preeti and Dr. Kinjal. There I will say contribution in our discussion definitely enlighten a lot on the subject of cardiology, and at least some other students, they tried to participate. That also I would like to appreciate. And of course, the whole show managed by Dr. Nehal and even the other coordinators, Dr. Vaishali and Madam Dr. Arti, and even I will say ringmaster, I can use the word, Dr. Yogeshwar, for the whole show, and our office bearers for providing this platform. So I'm sure that with efforts of all these people, we could make the 2 hours our learning, and I'm sure it is quite fruitful to all of us. Thank you very much. Personally, also, I would like to express our gratitude for giving this opportunity. Thank you very much, and over to you, Dr. Nehal.
Thank you so much, sir. I personally thanks both the experts, Chinmay also, his mentor, Dr. Ankur also. One more thing I wanted to say is today there were many students which were present, but they were either hesitating to speak something. So students, you have seen sir is guiding us to how to get it into the exam. So please participate actively next time. And one more thing, Dr. Paraman sir is there since starting of the case. So I thank you again, sir. Such presence of such stalwarts, they actually encourage students. So thank you so much, sir. Few words from you.
Thank you, ma'am.
Okay. Yogesh sir, anything from you? Then we can wind up the session.
Thank you very much, both our experts, Dr. Preeti Madam and Dr. Kinjal, and our mentor, Dr. Baldev Prajapati sir, and all three project coordinator, Dr. Hel Madam, Dr. Arti Madam, and Dr. Vaishali Madam. And RTS, congratulations, Chinmay and Dr. Ankur and the whole team. So many students, PG students from the GMC Surat, and our faculty also, Dr. Khushbu and Dr. Suchit, all are joined. And mostly Dr. Kanak Surma is also there. He told me he joined.
Yeah, he's there.
Yeah. So Kanak Bhai,
Thank
please.
you. Yeah, it was my pleasure to, after a long time, to attend some clinical meetings. It's remembering my PG days.
Yeah. So this session from your alumni group, GMC Surat.
Yeah.
So you and Nehal madam both. So thank you very much all the participants on the digital platform, and thank you very much Clarinet network. Thank you all.
I think just last word for the students. I understand that always it is a hesitation and shyness to the student. It's a physiological. So I don't have any complaint. But you know that at some time we have to break it. Then our further progress in the learning can occur. And second thing, you know, I'm gradually even learning that how to teach, particularly is from Dr. Amdekar and other senior teachers. And I remember Amdekar sir always said that let the students speak. The faculty should speak the less. And that's why I'm trying that as far as, you know, and students have the right to make even any comment, any mistake. And there you should understand that we are taking the help of so many, even the faculties and teachers. Being the general pediatrician like me, from that even we take the help of the experts, those who are exclusively working in that field. So that definitely they can correct us. And with the whole exercise, our idea that at the end, not only the students, but all of us can learn. And I think there cannot be any other the better method than this one in learning the clinical medicine. If you start to learn even from William Osler, you know that he was the person who started this clinical bedside discussion. Initially in our medical science also, it was classroom lectures like arts and commerce. They were not having the concept of this clinical medicine bedside. William Osler then thought that how we can give you the exact practical understanding. Then he told him students, let us go out of the classroom. We'll go to the patient. And what we are discussing, we'll see in the patient. And you know, that's the thing that how the clinical round, that even concept had came and which have become popular. And now we understand, and I'm learning, I'm more confident that even in the future with the advanced technology, whatever the technology comes, only the clinician is going to rule. And that's why we are insisting that learn the best clinical medicine. I'm sure that this will be the good sensitization to the students for the next case discussion. And I'm sure that they will gradually participate. We'll keep the patience. As a teachers, we'll have to keep the patience. And I'm sure that one day they are going to come. And then probably it is a success story for the teacher also. We cannot expect from day one to all the students. Thank you very much. Sorry to extend some time, but I think it was necessary. Thank you.
Sir, one sentence from my side, just for the students that up till this age also we are learning from the sir in the panel discussion also. So this is, they are having the great luck that they are getting this much time from you, sir. Thank you. Thanks a lot.
Thank you very much. Dr. Nehal.
One thing I'll say, Chinmay, that was a very good presentation.
Yeah.
You did very good on that. We all have been through that. So this is your first time you're doing it. We all did it. There's nothing wrong to say, I don't know. We also say we don't know. We all are learning. We still keep learning. And it's okay if you feel that you are right, even if your teacher or faculty says, no, you are wrong. It is okay to say, I think this is what it is. The teacher may be wrong too.
Yeah.
So it's okay to say that this is what I feel. You don't have to change your sentence just because the teacher said so. The teacher may be trying to sway you to say something wrong, but if you feel this is what I think it is, stick to it. Very good job.
Thank you very much.
So I remembering the college days of Dr. Preeti madam. Yeah. Okay, thank you. Nice to see all of you.
Yeah.
Thank you. Yeah.
So much.
Welcome.
Thank you very much, everyone, esteemed faculty. You have been very tolerant with me and very patient with me. Thank you very much.
Thank you.
Thank you very much, and good night to all the friends.
I have to join the other meeting at 9 o'clock. In between, I have to finish dinner.
Yes.
So,
thank you, friends. Good night.
Okay, bye.
thank you,
Thank you.
Thank you.
Provide us
Thank
this
you.
pleasure. Thank you, Sagni. for being the host today. Thank you so much. We can stop the streaming now.
Second,
Thank you,
Miss,
thank you.
next question, please, madam. Next question. Next question.
Next presentation. Next presentation is on CNS.
Yeah. Okay. So all are welcome on the next
Yes.
Saturday. Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you. Thank you.